increases with stress and disappears during sleep. This is the most important to differentiate it from epilepsy. Epilepsy does not increase with stress and can occur during sleep. Okay? I would like to highlight that tics have two types. Either simple tics, if the child have one type of motor activity. I mean either twitching of the eyes, jerking of the shoulder, or any other movement. But if you have combined two motor types like twitching, sometimes having twitching of the eyes, sometimes having jerking of the shoulder, we call these complex motor tics. If the tics are combined with vocal tics or utterances, we call this a Tourette syndrome. So Tourette syndrome is a complex motor tics plus vocal tics or utterances. It is autosomal. There are many theories actually behind Tourette syndrome. The exact etiology is still not known. Some researchers claim that it is genetic with autosomal dominant inheritance affecting males and females equally. Other research claim that it's due to environmental factors or mineral poisoning. Others say that it is autoimmune, what we call the pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. So there is wide variation in the pathogenesis of tic and Tourette syndrome, and the treatment is very complicated, and we'll discuss it later. Now, another types of abnormal movements. This infant is lying awake and aware in the bed. She has these abnormal flexion movements of the thigh and upper limb, and abnormal posturing of the upper limb, and flexion movements of the hips and lower limb, as you see. She is still aware and alert. We call this a gratification or masturbatory movements. Self-gratification behavior. Again, this male child is lying prone on the bed, having flexion movements of the lower limbs with adduction of the thighs. This is another form of gratification or masturbation. The same in this, the same one, different time. It might occur in normally developmental children with normal development or children with abnormal development. So the gratification are pleasurable behavior similar to masturbation, consist of rhythmic rocking movements in a sitting or supine position or prone position, or sustained hip flexion and adduction. Another type of paroxysmal movements, you see this child is playing. While playing with the left upper limb, he has abnormal movement of the right upper limb. You see the right arm having this abnormal movements. It's like flailing movement or rocking movements. And the left upper limb, left arm is doing a voluntary act. So, while doing a voluntary targeted act of the left arm, the right arm have this abnormal rocking movements. Now another child doing the voluntary movement of the specific voluntary movement of the right arm. The left arm is having this abnormal movement. This is the mirror movements. Involuntary movements of one side of the body, usually the hands, which occur as a reversals of an intended movement on the other side of the body. They are normal during infancy and tend to disappear before 10 years of age, coincident with myelination of the corpus callosum. Persistence of mirror movements may be a familial trait caused by disorder in organization of the corticospinal pathways, and if it persists, an MRI of the brain is indicated. Now, another type of abnormal events. This neonate is sleeping. While sleeping, he has abnormal jerking movement of the upper limb and lower limb. This is a myoclonic jerks of upper limb and lower limb simultaneously, like this. Now, he is sleeping, he is not awake.
Children remain asleep, there is no arousal.
Okay. This is a benign myoclonus. There is another video, I think. Oh, this is another thing. Okay. What we saw now is the benign myoclonus of early infancy. In myoclonus, the muscle activity may be asynchronous only in non-epileptic myoclonus. In benign myoclonus of early infancy, benign neonatal sleep myoclonus. Sorry, I just highlight the titles. The titles are the benign. Okay, the benign neonatal sleep myoclonus has characterized by repetitive, usually bilateral rhythmic jerks involving the upper and lower limbs during non-REM sleep. Usually remits spontaneously at 2 to 3 months of age. There is another abnormal event, but this is epilepsy. It's benign myoclonus of early infancy. This clinical event mimics infantile spasm, and it has spontaneous remission at 2 to 3 years of age. It's benign form of epilepsy, and it may resolve completely with sodium valproate. Another form of abnormal events is the episodic ataxia, which are two types. Type 1 characterized by occurring for brief episodes, seconds or minutes. The age of onset at 5 to 7 years of age. It lasts minutes to hours. It is a genetic abnormality caused by mutations in the voltage-gated potassium channel on chromosome 12. Characteristically, the patient may have a carpopedal spasm during the attack, and the clinical or EEG interictal myokemia can occur as a main diagnostic feature. In type 2, which is characterized by longer attacks for hours or days with interictal cerebellar signs, it's caused by mutation in the voltage-gated calcium channel gene on chromosome 19.
For example, this infant experiences sudden, rapid swimming or rotary movements of the arms.
In the neonate, there might be some abnormal movements. We call it automatisms. You see this neonate have a jerking movement of the left arm, and now it is like doing swimming movements. The EEG is normal, as you see. There is no paroxysmal or focal spikes or sharp slow or whatever event. This is called the motor automatisms. It is non-epileptic.
This infant demonstrates stepping movements of progression.
You see now a stepping movement of progression of the lower limbs. The EEG is unremarkable. and this is also a non-epileptic event.
And these motor automatisms consist of bursts of sudden pedaling movements.
It's called pedaling movements of the lower limbs. What is in the EEG is a muscle artifact.
Finally, motor automatisms and generalized tonic posturing may coexist, since their pathophysiologic mechanisms are the same. Here there are swimming movements of the arms and generalized tonic extension in an infant who is comatose and who has a depressed and undifferentiated EEG.
As mentioned, there is tonic posturing of the left upper limb with automatisms of the right upper limb. The two movements coexist because the underlying pathogenetic mechanism is the same, which is a brainstem release phenomenon. So, motor automatisms, rapid shaking movements of the limbs and jaw occurring spontaneously or triggered by touch and loud sounds. The movement suppression by stimulus removal or by repositioning of the affected limbs. There is characteristically no autonomic manifestations, not associated eye movements. The pathological mechanisms, it can occur with hypocalcemia, hypoglycemia, drug withdrawal, or in hypoxic ischemic encephalopathies as a major pathogenetic mechanisms. Another disorder mimicking epilepsy is the gastroesophageal reflux disease, Sandfer syndrome. It can occur in infants, causing paroxysmal attacks of generalized stiffening and obesotonic posturing. It may be accompanied by apnea, stirring, minimal jerking of extremities. The episodes often occur within 30 minutes after a feed. EEG is normal during these abnormal events. It can be diagnosed by video EEG telemetry when we combine the abnormal event with the electric discharge to prove that there is no epileptogenic, paroxysmal, or focal events during the attack. Last is shuddering attacks, characterized by rapid tremor of the head, shoulder, and trunk, lasting a few seconds, often associated with eating and recurring many times a day. Early manifestation, it could be an early manifestation of what's called essential tremor. A family history of essential tremor may be present. Spontaneous remission occurs before the second decade. This ends the first presentation. And now we'll move to the second part or the last part of my presentation.